brain health across the menopause transition. I'm going to start off by sharing my slides. Sure. Okay, there we go. So like I said, today's session is on cognition and brain health across the menopause transition. My name is Dr. Melissa Walsh, and I am a postdoctoral research fellow here at UNC. I work with Dr. Crystal Schiller, and Yamnia Cortez is also going to be presenting today. She was a faculty at UNC and then was welcomed to University of Iowa. So she's going to be doing her portion of the presentation there. Yamnia, I'll let you share anything you want to about your expertise and experience. I'd probably when your portions of the slides come in. For me, like I said, I'm a postdoctoral research fellow. And so I'm in the training stage of my research career, and my research is focusing on cognition and hormone therapy across the menopause transition. And so I had the wonderful opportunity to compile this presentation on how cognition can change and how your brain can change across the menopause transition. So I'm looking forward to sharing that with you today. See, there we go. So before we get started, I do want to just make a statement about language that we'll be using and inclusivity. So I will use the word woman or female to refer to people born with female genetics, so the XX sex chromosome combination and the associated reproductive physiology, so specifically ovaries. But this presentation is relevant to any person that meets these criteria, so having XX sex chromosomes and ovaries. Unfortunately, just at this point, English lacks a gender-inclusive word for this type of biology, so we're operating on the limitations of our current language. Humor me for a moment here. I'm going to read the text off the slide because I just think that this is a really nice anecdote and introduction to the topic of cognitive changes that can occur across the menopause transition. So between the ages of 30 and 60, many women will wake up one morning and wonder what hit them. Uncontrollable sweating or a barrage of brain fog and anxiety, disorientation, doing absent-minded things like entering a room only to wonder what made you go there in the first place. Belongings may be misplaced, with milk cartons finding their way in the cabinets and cereal boxes ending up in the fridge. Communication can become a challenge. Moments of sheer panic may arise when you struggle to come up with that word on the tip of your tongue, or you draw a blank on something you just said, losing your train of thought. And just when you hoped a good night's sleep might resolve these issues, sleep becomes elusive. With the rapid-fire onset and the intensity of these unexpected changes, it's no wonder many feel as if their own bodies are betraying them, throwing any woman in a tailspin of questioning herself, her health, and even her sanity. So this is an excerpt from Lisa Mosconi's recent book called The Menopause Brain. Lisa Mosconi is an eminent researcher in this area and the area of women's health and Alzheimer's prevention. So slightly tangential, but still related. If anybody's interested in learning more about how the menopause transition affects your brain, this is a really nice book written for a non-scientific audience, so accessible in terms of the content she conveys. We'll start with a little bit of terminology, just a quick primer, so we're all on the same page. This chart is showing the reproductive lifespan of a woman. So starting with the first menstrual period and continuing until the last regular menstrual period is referred to as the premenopausal stage. And when your periods start to become irregular and you might start to experience some of these menopause symptoms, that's defined as the menopause transition, or it's also referred to as perimenopause. And this transitional stage can last somewhere between 4 to 8 years, maybe more. And it's defined as ending after a woman's gone a full year without menstrual periods, at which point the postmenopausal period begins. So knowing this will help clarify the interpretations of what's to come. So just keep in mind, these are the definitions of some of the terms we'll be using. So I want to start off by saying that menopause affects your brain as much as your ovaries. Historically, it was just defined as a transition of your reproductive organs. So when your ovaries close up shop and you stop having periods and you can't get pregnant anymore, you have gone through menopause. But we now know that this transition affects your brain just as much. And this is really highlighted by this type of brain scan shown on the slide. This is called an FDG PET scan, which is essentially a map of how much glucose your brain cells are using. And so glucose is the preferred fuel for your brain cells. And so these darker red and orange and yellow areas are indicating regions of higher glucose use. So these brain cells are using more energy. And the darker blue and green areas are areas of lower energy consumption. And so what you can see is the brain to the right is the brain of a postmenopausal woman. And this is a prototypical example. And as you can see, this brain is overall kind of darker and more green than the brain to the left, which is the brain of a premenopausal woman. So this is a woman who has not yet shown any signs of transitioning to menopause. And so, I think, first of all, this is nice to show because it's validating in that the symptoms that are experienced with the menopause transition are really rooted in biology and they're rooted in the brain and they're real and you can measure them. It's also, maybe for some, it can be a little scary to see that there's this change in how much energy your brain cells are using from pre to post menopause. But the brain adapts. The brain is a very adaptive organ. It can get used to this new sense of normal. But as you can see, this is a significant decline in your brain cells' energy usage. It's about 30% decline on average. So this is just a really compelling example of the effects that menopause has on your brain. And these brain changes really make sense if you recognize that the brain is a hormone-sensitive organ. And we know that hormones are changing across the menopause transition, or also referred to as perimenopause. So this chart is basically a caricature of hormone changes across a woman's reproductive lifespan. It's not precisely accurate, but I think it demonstrates what we need to show. So in the premenopausal stage, you can see that hormones fluctuate on a cyclical basis with your menstrual cycle. And when a woman enters perimenopause, these fluctuations become unpredictable and erratic at times. So hormones might spike high, and then they might be low for months on end, and then they might spike again. And it's this unpredictability in part too that, is causing symptoms and these effects on the brain and on the body that we experience as menopausal symptoms. And then you can see in the postmenopausal stage, hormones achieve stability and they remain at those levels for the rest of the lifespan. And With once these hormones stabilize, the brain really can adapt to this new normal that it finds in postmenopause. Lots of menopause symptoms are brain symptoms, but for the purpose of this presentation today, we're going to focus a lot on mental abilities or cognitive symptoms. Scientists often refer to them as cognitive symptoms. But essentially, these are challenges like experiencing memory problems, difficulty finding the right word, difficulty with concentration, slower speed of thinking. But all these other symptoms that women might experience across the menopause transition can also be considered, at least to a certain extent, as brain symptoms, because all of these functions are regulated to some extent by the brain. So hot flashes and night sweats, for example, changes in mood, changes in sleep, more fragmented sleep, reductions in energy, changes in libido, all of those to a certain extent are regulated by the brain. And so I highlight this just because it's important to note that symptoms are really interconnected. Menopausal symptoms are really interconnected. So a treatment that affects one symptom might actually also benefit another. And that'll become, I think, especially relevant in some of the slides to come when we talk about treatments. It's estimated that about 60% of women experience brain fog during the menopause transition. But sadly, this is a symptom that doesn't get quite as much acknowledgement, or is probably not treated as effectively because it's under-recognized and under-acknowledged. But it's a symptom that can really affect quality of life. We talked about in the introduction this example of the cereal box in the fridge, but maybe even more compelling is the example of brain fog can have on work productivity and performance. It could in a jobs today and in this fast-paced world, slower speed of thinking, memory challenges, all of those things can really affect your ability to manage day-to-day tasks at work and even daily life. And this can exacerbate stress. This can affect your mood and your sleep, and it can really affect quality of life. So I'm hopeful for the future of our, the medical community's ability to consistently address this symptom, especially as we continue to understand it better as scientists. So let's start off with a little definition about, or a definition of perimenopausal brain fog. So it can affect different cognitive domains or cognitive skills. For example, someone experiencing brain fog might have difficulties with memory, and that might look like forgetting names or dates or events, or really just forgetting anything that would have been easy to recall before entering the menopause transition. This can manifest as reductions in focus, so having a harder time paying attention, and maybe feels like you can't pay attention for quite as long as you used to, or maybe you find yourself spacing out during conversations or during presentations. Speed of thinking might slow down, and this can look like tasks may take longer to complete. You might feel disorganized while you're completing tasks, and just in general, feeling slower to process information that's presented to you. Multitasking can become more challenging. So this might look like having a hard time remembering where you left off on a task after you get interrupted, say by a phone call or something, and you come back to it and you just have no clue where you left off. Word finding can also become more difficult. The sort of tip of the tongue phenomenon, it might be there, but you just cannot retrieve the word that you want. So let's also the definition of perimenopausal brain fog is a self-relative decline in cognitive abilities. It's not the same as a brain deficiency. And in order to highlight this, I think it's helpful to kind of describe how people quantify deficiencies. So usually how this is done is they give a, let's use memory, for example. They give a bunch of people a memory test and they compare one person's performance on that memory test to a bunch of people that are similar to that person. So say that would be a large group of midlife women. And if you look at this chart here, more people stacked on top of each other mean more people got that score on a test. So more midlife women got that score on a test. And if there's fewer people stacked on top of each other, fewer people got that score. So most people score in the normal range on a test like this, but there's also a subset of people that score below what we define as the normal range, and that would be considered a deficiency, whether or not it's mild, moderate, or severe. So say a score of 10, 20, or 30, for example, on this memory test would be considered kind of a deficient score. Now, it might feel, for someone going through the menopause transition, it might feel like their score is right here. They're really struggling compared to their previous abilities. But if you actually gave them a test, they would still be scoring in the normal range. So that's what I mean by saying this is a self-relative decline. It's not a deficiency. The good news too is that the brain fog won't last forever. And one of the studies that really illustrates this is the study of women's health across the nation, also called the SWAN study for short. And this was a study that looked at about 2,300 midlife women, and they tested them over the course of four years in different cognitive areas like memory and processing speed. And what this study found was that for women going through the menopause transition, they had more difficulty remembering information and they needed more time to complete tests compared to the women that were premenopausal and the women that were postmenopausal. Now, after the menopause transition, performance bounced back on these tests. So scores went back up. These are average findings. So, everybody may have their own unique experience. Some people may never have any brain fog across menopause. Some people might have really bad brain fog that gets all better, and some people might have bad brain fog that doesn't quite get all the way better. And maybe they'll seek additional support for that. But by and large, this is highlighting that these brain fog symptoms do get better postmenopausally. Now, brain fog can stir up fears of dementia for some people, but I want to emphasize that brain fog is not the same as dementia. The distinction between brain fog and dementia really lies in how debilitating it is. So brain fog during the menopause transition can make life harder, no doubt. And it can be really stressful. It can feel exhausting. It might make you feel like you're letting people down at home and at work, but you're still able to get by. Whereas the symptoms of early dementia often include things like cloudy thinking and difficulty remembering, but these occur to such a degree that they severely interfere with a person's ability to manage daily life. At which point, maybe family members or coworkers start to become concerned, and that individual may pursue follow-up with their doctor. This is all to say, though, that really, really severely debilitating brain fog, like, I mean, brain fog in general warrants follow-up, but this type of of really severely debilitating brain fog can warrant follow-up potentially with a specialist in Alzheimer's disease or Alzheimer's prevention. There's not a lot of prevention clinics out there yet, but they're popping up. So, if you have a really significant concern, contact a specialist in this area. It never hurts to have additional testing to better understand what's going on. And this kind of segues into the topic that, there is a known gender gap in Alzheimer's cases. Every 2 out of 3 Alzheimer's cases are women. So scientists have really wondered, why is this the case? And there's some growing evidence suggesting that for susceptible women, the brain changes that occur with menopause might raise Alzheimer's risk. And when I say susceptible women, I mean people with a really significant genetic or family history risk profile. And if this is the case for you, it may be worthwhile to seek an Alzheimer's prevention clinic to find out what you can do to just keep your brain healthy for as long as possible, starting as early as possible. That's really what these types of clinics are specialized for. So say you're going through perimenopause, or someone going through perimenopause, and you or that person are really experiencing brain fog symptoms that are frustrating you, and you are seeking treatment options. This is now the time to tune in, even more than you already have been. So we'll start with HRT, and also a little bit of background because of all the confusion that HRT stirs up and controversy potentially as well. So the big if some people maybe don't know about this, but I think many people maybe have heard about HRT, and they've heard about like the potential risks of HRT. And a big part of the reason that HRT, hormone replacement therapy, big reason that it got this bad rap was because of the media response to the Women's Health Initiative study, some of the reports that they put out in the early 2000s. So the media response was really flawed, and it contributed to a lot of confusion about what HRT is good for and what it's not good for. Just a little side note here, menopausal hormone therapy is kind of the new term that's used for HRT, but they're functionally equivalent terms, so they mean the same thing. The Women's Health Initiative study was the biggest clinical trial, even now, that's ever been done on hormone replacement therapy. And a clinical trial is basically the gold standard study that scientists use to determine if a drug is safe and if it's effective. And this study led to media claims that HRT increases risk of things like heart attack, stroke, breast cancer, and dementia. But these claims don't really apply so much to most people that would be seeking HRT. So one of the biggest problems in terms of translating this finding to most women is that the average age of participants in the study was 65. So most people were starting HRT in this study when they were already about 15 years post-menopause. And so it kind of makes sense that hormone replacement might have a different effect if you've already been postmenopausal for 15 years, because your brain's already adjusted to these, reductions in hormones. And it might not be as well able to respond to hormone replacement as the brain of someone who's going through menopause or just finished menopause. So that's one criticism. And then the people who participated in this study were recruited so that many of them were in poorer health because they wanted to study diseases of aging and how HRT affected these diseases of aging. And in order to study something, you have to have a certain number of people that actually end up getting these diseases. So they were recruiting people to start HRT, and they were recruiting people in poorer health so that within the span of the study, at least a number of them would end up getting these diseases that they wanted to study. So those are kind of the two criticisms. This was an older life population, and many of them were in poor health. And that doesn't really represent the average person who's looking to start HRT. So 20 years and many studies later, this is the updated kind of recommendation regarding HRT safety. And this is currently kind of the guideline from the North American Menopause Society, which is one of the governing bodies that makes recommendations about, menopause and its treatments. So hormone replacement therapy or menopausal hormone therapy, when it's prescribed by your doctor and when it's started during or within 10 years of menopause, is safe, barring any major risk factors that your doctor would be aware of. And it's also effective for many women to address bothersome symptoms. And even for women that are 10 years past menopause, when HRT is prescribed appropriately, especially at low transdermal doses, it can potentially still be safe. But this is something that you can talk to your doctor about to determine what your risk factors are. If you're 10 years post-menopause, but you're really interested in potentially pursuing HRT. If you want to learn more about the benefits and potential risks of hormone replacement therapy, this book, Estrogen Matters, is a nice review of the science on this topic, and it provides a more nuanced perspective on the risks and benefits. And it's written for anybody to read, so you don't have to be a scientist to be able to understand this book. So if you want to really educate yourself further before making a decision, this is a nice book. Now, moving more specifically to HRT for the treatment of brain fog symptoms, the current guidelines are a bit more limited here. So HRT is currently only recommended to address brain fog symptoms for women who undergo early or surgical menopause. And so early menopause might occur, it's defined as menopause that occurs before, the average age, usually around 40 or so. And this can be due to conditions like primary ovarian insufficiency. Surgical menopause is surgically induced menopause, done, a procedure done for a variety of reasons, but this can also induce menopause. If you remove your ovaries, you go through surgical menopause. Oftentimes this procedure is done before the typical age of menopause and it's a much more abrupt kind of transition than compared to the spontaneous menopause transition. So there's less research on HRT's benefits to brain fog during or shortly after the natural menopause transition, or natural or spontaneous menopause transition, it's sometimes called. That's what most women go through. But the lack of research does not necessarily mean there's a lack of efficacy for this population. It just means we need to study this topic more. There was in 2023 and this year, there were 2 meta-analyses performed relevant to this topic. And so a meta-analysis is basically a summary study. So it's a study that looks at all the studies that have been done to date on a topic. And then it integrates their statistics to find like, or to create just one unified statistic that represents findings across all the studies. So this is a summary of the findings of these meta-analyses. So both meta-analyses looked at starting HRT during midlife or during late life. And they looked at the two primary different formulations of HRT. So you can take an estrogen-only HRT, which is generally prescribed for women who have had a hysterectomy. So that means they don't have a uterus anymore. Otherwise, estrogen plus progestogen hormone replacement therapy is what's generally prescribed. And this is for women who still have their uterus. And the reason being that if you have a uterus, the estrogen is like supporting the lining of the uterus to build up, as it would in a menstrual cycle to support a pregnancy, or to potentially support a pregnancy. And what the progestogen does is it triggers the shedding of the lining of the uterus so that the tissue doesn't just keep building up, which can increase risk of things like endometrial cancer. So that's why they prescribe this combined estrogen plus progestogen HRT if you have a uterus. And that's why all these analyses are stratified across the different formulations. So starting with estrogen-only HRTs initiated during midlife, what these two meta-analyses found was that it was associated with improved performance on memory tests, and it was associated with a lower risk of dementia. Now, when you look at estrogen plus progestogen HRT, effects on memory performance were neutral. So memory didn't get better and it didn't get worse. And then effects on dementia risk were neutral. There was actually a trend towards lower risk, but it wasn't significant, which is basically a scientific term saying we're not so confident in this finding and we need bigger studies. So we'll call that a neutral effect. It didn't increase dementia risk, it didn't decrease dementia risk. When starting estrogen-only HRT later in life, so this would be 10 years or more after menopause, the effects on memory test performance, again, they were neutral. Not again, the effect was neutral, so they didn't go up, they didn't go down. Effects on dementia risk were neutral as well, so it didn't increase risk and it didn't decrease risk. And for women who initiated estrogen plus progestogen HRT later in life, this meta-analysis showed that memory test scores improved, but dementia risk increased. So that's a little weird. These were different studies in the different analyses, so it's valid that they could get different results, but it also highlights that this kind of inconsistency in the research is really highlighting the fact that we need to study this more. In particular, understanding what effect the type of progestogen has, because there's different types that were used in different studies, and the different types of progestogens might have different effects on the brain. So this really needs to be studied more systematically. So the summary here really is estrogen-only HRT is the area where we have the highest confidence that it can improve brain fog-related symptoms and also maybe reduce risk for dementia. Now, if you still have, if this is intriguing to you and you're having brain fog and you want to potentially pursue estrogen-only HRT, but you still have a uterus, there are newer formulations that have come out that are tissue selective. which means they affect your brain and maybe your bones. So those are the two areas where estrogen does good things. You take it during and after menopause, but these formulations do not affect tissue like reproductive type tissue, like your breasts and your ovaries, where it can sometimes do harm, as I've already described in the example of the uterus. Also, women with a history of hormone-sensitive breast cancer are not necessarily eligible to take HRT, so this could potentially be an option to explore in that context as well. So talk to your doctor if you're interested. Duavie is the name of this formulation. There's other types that are coming out, but Duavie is one that's been out for a little while. If you want to look outside of hormone replacement therapy, treating co-occurring menopause symptoms may help brain fog, as we kind of mentioned earlier. These are all brain symptoms of menopause. So depression can be a brain symptom of menopause. Insomnia can be a brain symptom of menopause. So if you treat one, it might improve the other. So considering treatments for depression may be warranted, especially if you're experiencing pretty, moderate to severe depression during the menopause transition. This may look like therapy. So cognitive behavioral therapy and behavioral activation are two of the approaches that have the best data to support their use to treat depression. And antidepressants may also be warranted. One of the benefits of antidepressants is that certain types actually help with hot flashes as well. So you get a 2-for-1 benefit. If you're experiencing depression, your hot flashes may also get better. Improving sleep and managing stress may help as well. But in this context, natural approaches are generally the first choice. And this may include things like yoga and meditation or exercise, which both have been shown to help with sleep and stress. Improving sleep hygiene, or creating habits that are support sleep can be helpful. This also may include limiting caffeine, which I know personally is challenging. And then therapy approaches are out there to address both stress and sleep. Cognitive behavioral therapy for insomnia is one of the first-line approaches that doctors will prescribe for people who are struggling with sleep difficulties and insomnia. And sleep medications are generally a last resort for sleep challenges and insomnia. ADHD treatments may be an option. So starting natural here, there are therapies geared toward addressing ADHD related symptoms. Generally, these look like therapies that help people learn strategies to better manage their daily tasks. This is probably going to be the most helpful for those that have a history of ADHD symptoms, whether diagnosed or undiagnosed, that are just really getting worse during the menopause transition, and they could really use some help to manage these symptoms. Stimulants may be an option, but like sleep medications, these are generally the last resort option because they carry certain risks. There have been 2 studies on perimenopausal women who have had substantial brain fog, and it showed that when they took stimulants, their symptoms improved significantly. But like I said, it's really requires a risk versus benefit analysis and a conversation with your doctor, because these carry risks. They might not be a good option if you have cardiovascular risk factors like high blood pressure. They may not be a good option if you have a history of substance use disorder, because they carry their own risk of abuse and dependence. And they can also interfere with sleep and appetite. And, interfering with sleep is kind of the last thing you need if you're going through the menopause transition. It's also warranted if you are currently taking different medications to talk to your doctor to evaluate your current medications to determine if any of them might be exacerbating brain fog symptoms. So this is a collaborative approach with your doctor. Don't just go discontinuing medications because you think they may be worsening your brain fog. Work with your doctor to determine if any of the medications you're currently taking could be worsening brain fog symptoms, and then decide with your doctor if discontinuing these medications might be appropriate. So that's an option, I think, that can help as well. So I'm going to hand it over to Yamnia now to go over some lifestyle type approaches that can be beneficial across the menopause transition.
Okay, thank you. Hi, everyone. My name is Jamnia Cortez, and I am an associate professor at the University of Iowa. I was previously at UNC, as mentioned earlier. And so I'm just going to discuss a few lifestyle and behavioral interventions. And some of these are specific to the topic today of cognition, but most of them are just about enhancing health in midlife because a lot of this is related. So some of them are also beneficial for bone health, cardiovascular health, and for some of the symptoms that were mentioned earlier that are related to cognition. And so one of the things, and particularly I also wanted to state that because midlife is just a great opportunity to start implementing, if you haven't already, certain lifestyle and behavioral changes to enhance future health. Unfortunately, I also wanted to say that in terms of our menopause research, lifestyle and behavioral interventions are one of the things that we have fewer research on. It is one of the things that I have been studying in order to then make recommendations, and there are definitely a lot of researchers doing different work in these particular things, but it is one of those areas where we need more work. So one of the things is cognitive training, which means different activities to keep your brain active, make sure that and to hopefully reduce some of the symptoms that we notice. And some of these could be doing puzzles, playing board games, reading, learning a new language, listening to music, which can also help reduce stress, which is one of the things that we mentioned earlier that increases in stress, and anxiety can also relate to cognition, as well as just doing different word games. These do have some benefit. We can go to the next one. The other things I believe is diet might be the next one.
Sorry, I was catching up on the chat. Yes, I switched it.
Oh, yes. Diet. And so, like I mentioned, there are several things here. So we want to make sure that we have sufficient iron and protein during the menopause transition. And so making sure that you're eating your green leafy vegetables, beans and lentils, nuts and seeds, dried fruits, poultry, fish, also calcium, which I didn't put in here, but calcium. So making sure you're eating your dairy products, foods fortified with calcium, tofu, vitamin D. So again, you can have, like cod liver oil, salmon, fatty fish, also for your omegas. Now, I kept playing with whether or not to put the tea and coffee in here because, again, it's the caffeine, but limited. So about a cup in studies have shown to help and have some cognitive benefit, but you don't want to have too much caffeine because, again, that interrupts with sleep. That may also be a trigger for vasomotor symptoms. And then also with some people who already are experiencing stress or anxiety or palpitations and things like that during the menopause transition, this might heighten that experience and may not be beneficial. So again, limited caffeine, but some benefits like a cup in terms of cognition. And then again, some phytoestrogens have been shown to also be important during this time period. So soybeans and soy products and things like that, and I already mentioned the beans. So a lot of the research, some of the pictures here are not only some of the things that I mentioned, but the bottom right is supposed to remind me to mention that a lot of these foods are things that are part of like the Mediterranean diet, which a lot of people do recommend during the time period. And then physical activity is another major intervention. And again, right now the recommendations are not specific to the menopause transition. So it's the general recommendation of 150 minutes of moderate physical activity a week. But you do want to have various types of physical activity. You want to make sure that because there is a reduction in terms of muscle mass, and because of the osteoporosis and bone loss that occurs at this time period, that you do want to include sort of resistance training and weights, then your aerobic activity, maintain balance activities, yoga, Pilates, Tai Chi, which also help again with stress management and sleep. That are symptoms that can be related to brain health. And as well as these lifestyle interventions are good for cardiovascular health. And we do see that in the future, there are links between cardiovascular health and brain health. So in general, these are good recommendations to maintain. And as I mentioned, there aren't in particular specific, like for the menopause transition, this many minutes or this type of physical activity. That's some of the research that hopefully is ongoing to give us more tailored tips. And then lastly, actually, when I do this, I have to think about another thing. No, you can go to that one. Sorry. It was me reminding myself. So lastly, sleep. And again, sleep is already initial during the menopause transition, but adequate sleep is important for brain health because it can improve thinking and concentration, better long-term memory, better work performance, and improve mood. And the recommendation is 7 to 9 hours. And I know I get 6. Like I myself, I'm here like get 7 to 9 hours, and I think my average is 6. So adequate sleep, and then it's difficult during this time period. So again, how do we improve our sleep to then help us improve our cognition? So you want to try to make sure that you have a sleep routine, good sleep hygiene. You're sleeping at with your lights dimmed. You try to use your bedroom for sleeping and not for other activities, not having screens on. You want to make sure that you don't drink caffeine a few hours before. Don't drink it like 3 hours before you're going to bed. Don't try to do physical activity or eat about 3 hours before bed. You want to make sure that you have that sleep routine. And then what I didn't include here are the importance of also stress management activities and how these stress management activities can improve sleep as well as cognition and or some of the brain fogging cognitive symptoms that you feel. So some of what I mentioned for cognitive training, like the music and the physical activity, are like yoga and Pilates are also good stress management activities. The puzzles, some people do aromatherapy as something that helps. Occupational, so if you occupational therapy or different, just art, coloring, crocheting, something that you enjoy to do, taking walks out in nature, or just outside gardening. These are all activities that can also help with stress management as well as sleep and cognition. And that is what I have for this part. Yeah.
Thank you, Yamnia. And here, so I'm just going to kind of highlight the take-home messages from this presentation. So, to start, like menopause affects your brain. It can lead to symptoms like brain fog. And it's also just a good opportunity to think about brain health and think about what you can do to keep your brain healthy, both during this more challenging phase, but maybe for the long run into old age. And so, like Yamnia just presented, lifestyle changes can help brain symptoms of menopause, and they can be very powerful tools. In some cases, maybe even more powerful than certain drugs we have available. So implementing things like a consistent or a relatively consistent exercise routine, adopting a nutritious diet that's high in, plant fibers, and, other healthy nutrients like omega-3s and vitamin D, making sure you have a balanced diet, or just adding a really nice smoothie with lots of vegetables and maybe some of those flavonoid-rich berries into it can be a great tip or tool just to get you started on the pathway to a more nutritious diet. Sleep habits are crucial, and they impact your brain health and also your cognitive performance. So does stress. So if you can find something that you love to do that helps with your stress, this is a great time to maybe start exploring the different things out there that are, you got to find what you love, because that's the only way you're going to do it consistently. So whether or not it's gardening or yoga or beautiful walks out in nature, now is a nice time to start exploring. Prescription options can also help with brain fog symptoms, which is more of what I covered. So HRT, the best evidence in terms of its effects on brain fog symptoms or its benefits to brain fog symptoms, the best evidence is for estrogen-only formulations. This is not to say that estrogen plus progestogen formulations, they could actually be beneficial. We just don't have as much research on it, and we need to understand more how the type of progestogen that a woman takes affects, brain fog symptoms and then other related brain health symptoms like dementia risk. But if you're interested in pursuing an estrogen-only HRT, but you have a uterus, so, a doctor might normally say you're not eligible for estrogen-only HRT, there are newer formulations out there. They're called SERMs, selective estrogen receptor modulators. Duovy is an example where it targets estrogen, it targets the receptors for estrogen in a tissue specific way. So the estrogen gets to your brain and maybe your bones where it does good things, but it doesn't get to your breasts and your uterus where maybe it can cause harm. So talk to your doctor if you're interested. Duovy is one of those types of formulations. Treating co-occurring symptoms can help, especially, for example, if you're struggling with some real depression or bad insomnia or like really chronic stress. Exploring treatments to alleviate these symptoms could actually also help your brain fog. For depression, therapy and antidepressants are both options, and antidepressants can have a 2-for-1 benefit of also addressing hot flashes. Approaches for insomnia and stress are more the lifestyle changes that Yamnia and I discussed a little bit. Therapies developed for ADHD may also help, especially if you have a history of ADHD that's gotten worse across the menopause transition. Ideally, starting off with maybe a therapy, finding a therapist that specializes in strategies to address ADHD-related symptoms. Stimulants could also be a last resort option, which have shown some effectiveness in terms of alleviating perimenopausal brain fog. But importantly, find a provider that listens to and acknowledges your experience and is educated on brain symptoms of menopause, and really collaborate with them to develop a holistic approach for your experience. I mentioned the menopause brain and estrogen matters earlier in the presentation if you want to learn a little bit more. For people with more specific needs, the XX Brain is a nice read if you have a fear, like significant fear or a lot of family or genetic risk for dementia. This specifically is a book on strategies tailored for women to reduce risk of dementia and Alzheimer's disease, but starting early in life. So more prevention type strategies for women. And ADHD 2.0 is just a general book about strategies to manage attention challenges, which might be really helpful if, you know, these types of symptoms are exacerbated across the menopause transition. So these are some slides on the studies that we're currently recruiting for. Kate, do you want to go over or who does someone want to go over this, or should I?
I can do it.
Okay.
Let me see if I can turn my video on. Okay. Hello. Thanks everybody for attending today. We just wanted to keep you aware of some studies that we have going on. A part of my mission in doing these seminars is to provide you all with information that's high quality and based on science, because there's so much misinformation out there. And there's been a general lack of information because until recently, there hasn't been much funding to study menopause and the brain and all these things that are so important to all of us. And so sort of the two things I've been doing is trying to take the information we do have and put it into the hands of people who need it the most, which that's what the seminar is about, but then also to build our knowledge base and really understand how hormones impact the brain and mood as we transition to midlife. So that's where this study comes in. It's funded by the National Institute of Mental Health. And we're trying to understand how hormones regulate the brain and mood. And Dr. Walsh is studying how it improves cognition during this menopause transition. And so in this study, we ask people to take estrogen for 3 weeks and then have some brain scans. And so you would meet with our team 6 times. We pay people for if they do all of that stuff, you get $1,000, and you can learn more either by snapping a picture of that QR code or going to our website.
I'll give people 1 second to snap a picture just in case. Okay. Now I will move on to the next slide. Oops. Here we go.
And then we also have different folks that you can meet with at UNC. I've been hearing time and again that it's so difficult to find providers who are up to date on the literature and understand that hormone replacement therapy is safe for most people, because that most of the knowledge that most clinicians are operating with, is like 20 years out of date. So these folks are practicing at UNC and combined sort of comprise a menopause clinic at UNC, and I feel confident in their abilities to help folks through this period. And so highly recommend them and wanted to give you that information. I've spoken with some other folks outside of UNC who are building a list of qualified providers through a Facebook group. And once we get that sort of rolling, then I'll provide you all with that information as well, because I think you may be the best resources for knowing who the good providers are out there in the community. And so we can hopefully build some collective wisdom around this. All right, and then in our clinic, we have a midlife women's mood disorders clinic. We're in the Department of Psychiatry, so it's based in, we're saying women's mood disorders, but we really treat all kinds of different things for people during and after menopause. And so on the psychology side of things, which is the part that I run, we meet with people and talk about kind of everything that was covered in the presentation today. So if you're having brain fog, what are those lifestyle things that we know can improve brain health and cognition and also mood, and how can we build that into your schedule? It's really easy said, but not easy done. So making any kind of lifestyle change is hard. And so if you're interested in doing this and like having some basically health coaching around it, we can help you with that. We can also connect you to our OBGYNs who can prescribe hormones if we feel like that might be helpful. Dr. Margot Nathan, who's here today, and can help answer questions. She's the psychiatrist and director of our clinic, and she can help, prescribe other things too, and help review medications and that kind of thing. So, yeah, I think we've put together a good multidisciplinary team, and just wanted to make you aware of this as well. And you can call that phone number to find out more. Unfortunately, our website is like ridiculously out of date and we need to get more information on it. So you won't find much information on our website, but we're working on it. Okay, these are just some references, but we can make the slides available to folks so that if you want to look at the academic papers now, God help you, most of you, if you want to do that, because academic papers are written in a language that's really hard to understand and quite boring. But if you want to check the facts, you're welcome to look at those papers, and happy to answer questions now. I've been trying to answer them as we go along in the chat, and the place where I left off was Jazz's question: what's the value of an estradiol plus progesterone medication versus estrogen only? And so the only reason to add progesterone is to prevent the uterine lining from building up. So estrogen causes your uterine lining to build up, and progesterone prevents it from doing that. And so back in the 60s and 70s, women were getting estrogen only, and it was causing their uterine lining to build up. And over time, if that's not sloughed off, like with a period, then it causes uterine cancer. But when you add progesterone to that, then it prevents that from happening. Progesterone seems to have no impact on mood, or a negative impact on mood if you're sort of sensitive to progesterone. It doesn't seem to have any beneficial impact on mood. And as far as my read of the literature, and Melissa, you can jump in, I don't think progesterone has any positive impact on cognition either. I think it's mainly tied to estrogen. And so there are folks out around in places claiming to be menopause experts who will prescribe bioidentical progesterone, or say that you're estrogen dominant and you need progesterone to I don't know, re-regulate things. And it costs a lot of money and seems to have no beneficial effect other than sort of the placebo effect that you get from feeling good that you're taking something that might be helpful to you. So estrogen is really the active ingredient, and you can think of progesterone as a necessary add-on to mitigate risk. But the formulation that we talked about from Pfizer called Duovy combines two medications. So it has estrogen, and then it has another medication that blocks the estrogen receptors in your uterus and breast tissue, so that it doesn't cause the uterine lining to build up. And that in that way, you don't have to take the progesterone, because some people, when they take progesterone, it makes their mood worse. And so, and also, as Melissa was talking about earlier with the cognition studies, the estrogen alone seems to be the thing that improves brain fog and cognition during the menopause transition. So if you wanted to avoid having the progesterone and you still have a uterus because you haven't had a hysterectomy, then the way to do that would be to take Duovy. It's still under patent with Pfizer, and so it's expensive right now. The patent's going to run out, I think, like next year. In which case I'm hoping that some people will come out with generics. But right now it's still under patent, so it's a bit expensive. And so some insurance companies will want you to do estrogen plus progesterone first before trying Duovy. But if you make the case that you're progesterone sensitive and you don't want it, then your doctor may be able to help you get the Duovy covered by your insurance company.